Hello, ازيكم عاملين ايه؟ I'm Dr. شيرين سيد. اخباركم ايه؟ We are talking today about the cannula entry point and how to correct the wall areas of the face by cannula points. There are different areas target to be treated by fillers, okay? First of all, we have to put pillars of treatment, okay? First one, we have a longitudinal ligament of the face. Longitudinal ligament of the face made by the orbital retaining ligament, zygomatic cutaneous ligament, lateral masseteric cutaneous ligament, and here is the mandibular ligament, also platysmo-auricular ligament. If we and lateral temporal septum, if we make a line of all this called the line of ligaments or Y-shaped line of ligaments, all injection lateral to this line aimed for lifting and grazing the anterior descent of the face, and all injection medial or anterior to this line of ligament aimed for volumization. Okay, first we have area called temple. Temple area, if we treat the temple area, can be treated by different methods. We can put a bolus of gunshot technique fillers deep on bone, but now we have to use a very high J prime filler and ask your patient to open the mouth. Open the mouth, please. And 1 cm up, 1 cm down, feeling the pulsation of the facial artery. It's not felt, so it's my joker point. Put a gunshot technique while she's opening the mouth to relax the temporalis muscle. Put your bolus deep on bone very slowly, so that the patient will not meeting a headache later on. Okay, and put approximately 0.5 milli in each side bolus gunshot technique. But this treatment can treat the anterior temple only. The posterior temple may need some treatment by cannula. Where can I enter by cannula? We have 3 entry points by cannula. First one, we can enter from the zygomatic arch, but now I'm subdermal or subcutaneous using low G prime filler just under the skin. And this is tricky and must use 22G cannula or larger cannula. The other one from the temporal crest, I go like that laterally, and now I'm interfacial plane. Now when I'm going up to down, I'm interfacial plane in the temple. And the third point, I can inject it from here, from anterior hairline, but it's very risky because I have a superficial temporal artery and frontal craniofacial nerve crossing along the Bettinger's line. So I have to be very cautious while I'm entering from the hairline. Now I'm also going in the interfacial plane. And this is the 3 techniques or 3 ways to treat the temple by cannula. And this is my first area to be treated. Second one, it's called the zygomatic area. Zygomatic area, it's along the anterior and lower border of the zygoma. I must feel the zygomatic arch, I feel the anterior border, and then the lower and the superior border of the zygomatic arch and the inferior border of the zygomatic arch, and this is zygoma. When I treat the zygoma, I must be exactly deep on bone, or by needle, or subcutaneously by cannula. But there is 3 risk dangerous structures I have to respect. First, 2 centimeters above the zygomatic arch, I have middle temporal vein and zygomatic-facial artery. It runs like that and go through the zygomatic-facial foramina. I must respect these vessels and not injecting deep above the upper border of the zygomatic arch. And then 1 finger breadth below the zygomatic arch, I will meet the transverse facial artery. And transverse facial artery is risky and dangerous. It's a bruising vessel, not occluding vessel, thank God, it's not occluding vessel. يعني when I injure these vessels, it make a bruises and big hematoma must be treated at once. And so that I should respect the zygomatic to be exactly on the bone. By needle it's easy, but by cannula, how to treat the zygomatic arch by cannula? Where my entry point? This is my joker entry point for the lateral side of the face. I take a line from the lateral canthus, meeting a line from the lower border of the ala, and meeting the other line from the inner canthus, and this is called the nasojoker port of entry or joker point of entry. Through this point I can correct. Through this point I can pinch the skin and going subcutaneously, and when you screw in your cannula, you should hold your cannula from the hub. Okay, pinch your skin and going laterally subcutaneously, making a little bit fanning, but your fanning must be exactly between the upper and lower border of the zygomatic arch. You have to be exactly between the upper border and lower border of the zygomatic arch, not going up or not going down, even if you are subcutaneously away from the vessel. This is giving a very heavy lock to the lateral cheeks, okay? Going again, please focus. Yes, we are going here from the joker line laterally toward the zygomatic arch and making a subcutaneous. From this joker point, I can go also medially through this compartment. What is this? This is a deep medial cheek fat. This is a very important compartment to be treated to give anterior projection of the cheeks and also to indirectly correct the tear trough. Indirectly correct the tear trough. From this point, I can lift my tissue and going perpendicularly angle 90 by cannula. Yes, by cannula, exactly in the piriform space or premaxillary space. This is a joker point and joker entry point. It's really marvelous. From this point also, I can go to this area. It's called infrazygomatic or pre-auricular area. Take high care in this area. I have parotid gland. Yes, I have transverse facial artery and should respect the Auger curve. I shouldn't obliterate the Auger curve, so this area must be injected very gently by cannula from this point or from this point or from this point, very gently and superficially by small amount, and this is called the pre-auricular area. And this is my second point to be treated. We talked about the temple, we talked about the zygomatic arch, we talked about the pre-auricular area, and now we are going for the next video. Waiting you. Bye.